Okay, we're ready to go.
Good. Thank you, Cheryl. Thank you very much. And colleagues, good evening. Good evening to these, welcome you to this occasion. It's an educational occasion again. This is a G-ECHO session, which is hosted by the Gastro Foundation in association with the Project ECHO, University of New Mexico. So for this occasion, we are going to welcome Dr. Godknows Shamhuyashe. He's going to be the presenter. I am the facilitator, Dr. Ramonate from Free State. Dr. Shamhuyashe is from, what's the name? University, I know Wits. Give me the name.
Hospital.
Yeah?
It's Sani Baragwanath Hospital.
Good, thank you. Right, so, all right, so after the chat box will be open for questions. So I think now it's time for Dr. Shamhuyashe to take the floor. Okay, go for it.
Okay. Good evening, colleagues. My name is Dr. Godknows Shamhuyashe. I'm a medical gastroenterology fellow at Christian Baragwanath Academic Hospital. So the topic of this evening is upper GI bleeding. That's focusing on peptic ulcer disease bleeding, varices, and also hemorrhagic cysts. So the outline of my presentation, I'll define what upper GI bleeding is, then also move on to the pre-endoscopic assessment of a patient and how we would approach a different peptic ulcer disease, and also in terms of their endoscopic management and the approach to variceal bleeding, and finishing off with the hemorrhagic cyst management. So what we mean when we say upper GI bleeding, that's the bleeding originating from the proximal to the ligament of Treace. That's your duodenal flexure. That's in about 85%. So any bleeding from the mouth up to the duodenal flexure is defined as upper GI bleeding. So it may be acute or chronic, or it can be slow or brisk, or it can be obscure or overt. That's depending on the underlying etiology and also on the bleeding rate and chronicity of the blood loss. So it can be classified as non-variceal or variceal bleeding. With non-variceal, you have got peptic ulcer disease and also the erosive gastritis and malorified tears, Delafoy lesions, malignant angiodysplasia. On the variceal bleeding, you have got your esophageal varices, gastric varices, and also portal hypertensive gastropathy and GERD. So in terms of the frequency of causing upper GI bleeding, we find that peptic ulcer disease is actually the ones which is more prevalent, with a 35 to 50% of all the upper GI bleeding. Then you have also your erosive gastritis and variceal bleeding being common in about 5 to 20% of the patients. Then we also have the other etiologies like I mentioned earlier. So what is important when you see these patients is your history is very important. You need to ask about the duration of the bleeding, the frequency, the amount, the type of bleeding, and also the stool color is very important. And any other associated gastrointestinal symptoms they might be having. It is also important to assess comorbidities, whether they've got liver disease or whether they have got some coagulopathy and cardiopulmonary diseases, which might need them to use anticoagulation medication. And also the history of the medication use is very important. You find that some patients will be on aspirin or they use NSAIDs maybe for chronic epigastric pains. Some might be alcoholic and smokers, which put them at high risk of having upper GI bleeding. And the procedural history is very important. Some might be having recent surgery or a procedure being done like an endoscopy or a radiation. And as you assess and take the history of this patient, it's also important to anticipate that you might end up doing an endoscopy earlier. So you might need to get consent from the patient, whether they are consentable to the procedure, and also ask them when was the last time they ate. Like I mentioned earlier, the manifestations which include hematemesis, coffee ground emesis, and also they can have hematochezia or melena and other general symptoms such as syncope, fatigue, and palpitation, of which you need to triage your patient early, with early resuscitation being in place, and also early endoscopic evaluation so that you improve the outcomes of these patients. So there are certain risky factors which these patients they might have, like for those who have got peptic ulcer disease, a history of NSAID use, or those who have been taking aspirin, and also patients with H. pylori infection, and those who have got who smoke tobacco and are using steroids. They are also they've got high risk of developing peptic ulcers, and also the patients who are some patients can develop stress ulcers, especially those who are being managed in critical care ICUs, those who have been intubated for more than 48 hours, and also patients who have got severe burns. And also patients who have got esophagitis, when they're in supine position, they have got high risk of ending up having upper GI bleeding. And also patients with liver diseases or portal hypertension, they tend to have varices, which can end up bleeding. So you need to risk stratify the patient. This can be done pre-endoscopically or post-endoscopically. With the pre-endoscopic evaluation, you have got various scoring system, which can be used for the non-variceal bleeding. We have got the Glasgow-Blanchford score and also the clinical Rocco score. But the clinical Rocco score, it encompasses both pre-endoscopic and post-endoscopic score. We have got the Habinga score and also the artificial neural network score. And AIM score. There are different types of scoring system which you can use. But the most common one which we use is the Glasgow-Blanchford score, of which the risk factors which you check at admission, you need to know the patient's urea, hemoglobin, and also the systolic blood pressure, the heart rate, uh, whether they've got melena, whether they are symptomatic, whether they've got a syncope or not, or also the presence of other systemic diseases like hepatic diseases or cardiac failure. So your assessment gives you an idea of whether you need an intervention or not. So a score of 0 to 1, it's a low risk patient. They might not need hospitalization. You might consider having an outpatient treatment. But if a patient has got a score of more than 1, that's a high risk patient. And if they are, some of them, most of the time, they will be hemodynamically unstable. So they will need inpatient management, of which you need to admit them. The Rocco score, the pre-endoscopic evaluation, it just estimates the mortality, of which you'll be having your age of the patient. You need to assess whether your patient is shocked or not, and also the presence of comorbidities, which can be cardiac or renal or liver or any malignancy. Then endoscopically, you might need to check any lesions which are found. It can be no lesion. You can find some lesion depending on your assessment. So we move on to resuscitation. It's very important to do the usual ABCD assessment of resuscitation. You need to closely monitor the airways, the clinical status, and also the vital signs and the urinary output of the patient to see whether they are stable or unstable. And your examination should include a rectal examination. We need to put these patients large bore IV lines as they may deteriorate anytime, and we need to collect the bloods and also need to cross-match these patients for possible transfusion. In terms of fluid resuscitation, can be restricted. You can either be a bit of restrictive or aggressive, depending on how the patient is shocked. But with the red cell transfusion, restrictive approach is usually um, it's usually has got a best offer, has got a best outcome. So in terms of blood transfusion, your target HB should be between 7 and 9 grams per deciliter. For those who have got active cardiac disease, you aim for an HB of around 10. And as you do that, you need to risk stratify your patient, whether they've got high risk or a low risk. And also, depending on your triage, it depends where you are going to admit them, whether they need an ICU or just an inpatient admission. And also, it gives you an assessment of when to do your endoscopy. And also, you might be in your thinking that later on, if it's a patient who is more unstable, you might need to consult some colleagues, maybe the ICU team, and also surgery or interventional radiology if it's available. So in terms of transfusion strategies, restrictive strategy was found to be more effective as compared to liberal transfusion, according to this study where they enrolled 921 patients who had severe upper GI bleeding. Some were assigned to the restrictive strategy and others to the liberal strategy. And the probability of survival at 6 weeks was higher in the restrictive strategy group than the liberal strategy. And also it was found that those who received restrictive strategy blood transfusion, their risk of further bleeding was less as compared to the liberal group. And also the adverse events occurred in 40% as compared to 48% of those who had liberal transfusion. So its advantages, it showed that there was a decrease in the transfusion reactions, also a decrease in the risk of thrombosis, and also there was a decrease in the risk of ischemic events, and also improved survival at 6 weeks. So when do you need to intubate patients with upper GI bleeding? So those who have got massive hematemesis and patients with altered mental status, and where you anticipate to do airway protection. And there are some certain consideration where the patient might be having a risk of aspiration, and also those who have got a potential risk of cardiac adverse events, those who are in shock and tend to deteriorate. So before you take your patient for endoscopy, there are some modalities which you might need to give these patients. One of them is the prokinetic agents, pre-endoscopic erythromycin. So it has been shown that it gives adequate gastric mucosal visualization. And ideally, you need to give it 20 to 90 minutes before the endoscopy, that is according to the ACG guidelines. And most of the time, there's no need for a second look endoscopy. And also, we find that these patients have got a reduced length of stay. But the problem is, at times, depending on where you are, it may be difficult to get erythromycin for use in patients with upper GI bleeding. The other option, which is there, is metoclopramide. It can be used, but there is actually limited data on its use. That's the option which you can have if you can't find erythromycin. So the PPIs can also be used, and the ASGE guidelines, they recommend use of IV PPI before endoscopy. And according to the ACG 2021 guidelines, they didn't reach a consensus on whether to use PPIs or not before the endoscopy. But some studies have shown that the rebleeding rates at times they get reduced, and also there's need for surgery in these patients. They tend to be reduced. So for the timing of endoscopy, you need to fully resuscitate your patient. Your patient should be hemodynamically stable. And in most of the societal guidelines, they recommend early endoscopy, that is in less than 24 hours. And very early endoscopy that's less than 12 hours, it can be considered in patients who are hemodynamically unstable, who are refractory to resuscitation, and those patients who have got frank hematemesis, and maybe patients who have got contraindication to the interruption of anticoagulation. And emergency endoscopy, that is less than 6 hours, is usually associated with worse outcomes. Likely these patients, they are under resuscitated, and usually there is insufficient time to stabilize these patients. So within 24 hours, and maybe between 12 and 24 hours after hemodynamic stability, that's most of the time is the proper time for endoscopy. So as you prepare for patients for endoscopy, you should have think about your endoscopic toolbox. That's what you need in this patient. There are lots of therapies which you can use, like injection therapy, mechanical and topical. So you just need to know the equipment or the agents you have at your unit, whether they are available, and how is the access to them, of which you need to have immediate access to multiple devices. And this has been shown that it improves the outcome actually. And you are able to tailor your therapy. As you know, different bleeding lesions, they might require different approaches. So in that way, you reduce your morbidity and mortality. And if your endoscopic toolbox is adequate, you reduce also the rebleeding rates, and there's decreased the need to repeat endoscopy or surgery. And as a result, there is enhanced procedural efficiency. If everything is in your scope room, there's no need to run around looking for extra materials or extra equipment to use on the patient. So moving on to peptic ulcer bleeding, there are factors which are predictive of a poor prognosis after hemorrhage from peptic ulcer. So these are the patients who are at high risk of having a rebleed even after some intervention. Those who are elderly, and those who have got severe comorbid medical illness, and also patients with coagulopathy, and patients who had multiple transfusion requirements, and also those patients who have got difficult ulcers which are in higher areas, like in the higher lesser curvature areas, and also like the posterior duodenal bulb, the areas which are very difficult to control bleeding. These are the patients who have got poor endoscopic, poor prognostic outcome. So how do we classify the peptic ulcers? We use the forestry classification, of which there are different stages from 1A to 1B, 2A, 2B, 2C, and 3, depending on the endoscopic findings. So in terms of the rate of rebleeding of these ulcers, you will find that stage 1A, usually patients have got about 60 to 100% chances of rebleeding, with stage B reducing to 50, and also stage 2A, B, and C, the rebleeding rates also goes down, with the forest ulcer 3 having the low risk of rebleeding, that is about 3 to 5%. In terms of the management, forest 1A is active bleeding, and it's a sprouting hemorrhage, of which you need a dual endoscopic therapy most of the time, and especially together with the 1B. And patients who have got a visible vessel, like the 2As, they also need dual endoscopic therapy, and also the PPI infusion for about 72 hours. The patients who have got an adherent clot, that's your forest 2B, it's kind of a gray area where one might need to, you can either leave it, but it is advised that you can leave it if you are not that much comfortable with what you are going to see, or if you are not that experienced. But ideally, the patient, if you are not 100% comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see, or if you are not that much comfortable with what you are going to see you need to aggressively irrigate that clot to remove it, to see what's underneath, and then we can remove it with a snare, and then you can either do your dual therapy management. Either you have injected your epinephrine or saline, then another modality for in terms of hemorrhagic control. So with the forest 3, with the flat pigment spot, that's your 2C, and in the clean base ulcer, that's forest 3. Usually there is no endoscopic modality which you can use. PPIs are the modality of therapy which you can give these patients. So these are the endoscopic managements which you can use. There's injection, adrenaline, of which adrenaline is not used as a monotherapy. You use it with another modality. Sclerosant, they've fallen off now in terms of peptic ulcer management because of other modalities which have been found to be more effective. There's also use of thrombin or fibrin. And you have got your thermal options, which of the contact type where you can use the gold probe or heater probe, and also the non-contact, your APC and laser, and the mechanical form of management where you can use over the over the scope clips or through the scope clips, and the hemostatic powder sprays, and your that's also, and also your Purastat. So the modalities which you can use, they vary. It depends on the availability at your institution. But however, there are some risky factors which are there for failure. You might find that large ulcers, which are more than 2 centimeters, they might be difficult to manage, and also those in the posterior duodenal bulb, and patients who are hemodynamically unstable, and those who have got coagulopathy. These patients, their risk of rebleeding might be very high. So in terms of the injection, like I said earlier, the adrenaline, you can use it as you don't need to use it as a monotherapy. It causes vasoconstriction and tamponade. You use it together with another modality. In terms of the volume you can use, large volumes of more than 13, they've been found to be better than low volumes of about 5 to 10 mils for reducing recurrent bleeding. And injection of about 30 mils of diluted epinephrine can be effectively is very effective to prevent recurrent bleeding with a low rate of complications. So these were some of the studies which were done some years back, and so the volume which probably works depending on the size of the ulcer which you are injecting, between 13 and 30. That has been adequately studied. Volumes, large volume like 40 mils, there's high risk of perforation, and those patients can also complain of some epigastric pains after the procedure. And argon plasma coagulation, that's one of the modality which you can use, where the probe, it has got the plasma jet flows path with the list. It has got different probe openings which can be axial, sorry, and also can have a side fire or a circumferential fire, of which the coagulation, it depends on the power setting and also the duration of application and the distance from the probe to the from the probe tip to the target tissue. And this one is not ideal for forest 1A and 2A. In terms of hemostatic powder indications, these have come handy in terms of peptic ulcer management, and the indications, they are the 5 cans where you can use them in patients with peptic ulcer disease, bleeding peptic ulcer disease. So this is where you can't stop the bleeding. Those patients who have got refractory bleeding, and where you can't reach. So these are the difficult positions. That's like your cardia and the posterior duodenum. And where you can't finish, firstly, patients who have got diffuse bleeding, those with ischemic ulcers, GERD, and radiation. And where you can't touch, these are patients who have got risk for perforation, especially those with thin-walled ulcers, and also those which have got bleeding from the ampulla, and where you can't touch, like the patients who have got bleeding neoplasm, they are very difficult. So these are the 5 cans where the hemostatic powders can be used, of which there are different modalities. The common one, which we use at our institution, we have got the hemospray. It has got the greatest level of evidence, and it lasts for about 24 hours. It promotes clot formation and mechanical plug, and it can be used in anticoagulated patients also. And but it has got some few limitations, of which one of them is that you can't suction, and you must make sure that the scope channel is dry, and you cannot, if you cannot get to the tip, you cannot get the tip wet, or otherwise it clogs. So some facilities, they use the bone wax, which can makes it not to clog. Then we have got other modalities like next powder, which it shows a blue visualization, and it becomes a gel, and it's more adhesive. It lasts for about 48 to 72 hours. It's not approved for lower GI bleeding. We also have got the endoclot, which has got an adjustable delivery, and it's not for arterial bleeding. It absorbs water from the bleeding lesions, concentrate the platelets, clotting factors, and red blood cells, therefore promoting the clot formation and a gelled matrix. Then we also have Purastat, which it's extremely user-friendly. It's a viscous liquid which is applied to a bleeding area, and it forms a transparent gel matrix which induces hemostasis, and it does not clog. So there are various modalities which in terms of hemospray, which you can use, and you just have to know what's on your disposal. And uh, moving on to through this the scope clips. So these ones, you can use them to directly close the vessel, and it provides a durable hemostasis. But they are not ideal for oozing or bleeding vessels, and or in areas where there is poor visualization, and also in areas where there is a very fibrotic and hard ulcer base, or if the defect is very large, of which in those cases you might need to use over the scope clips like your Orthescope. It grafts more tissue and deeper layers compared to the conventional clips, and you can use it for failed prior endoscopic therapy. But the difficulty is that it's kind of technically demanding, and also it can be difficult in narrow or angulated locations. So you have the Ovesco, and you can also use the padlock as one of the scope clips. So moving on to variceal bleeding. So these patients, you suspect them, especially patients who have got chronic liver disease and those who are alcoholic with impaired liver function tests, with also jaundice and coagulopathy and ascites. These are your warning signs. Some might be known, some might be not. They might be the initial presentation with an upper GI bleed. So usually variceal bleeding, they develop above 10 millimeters of hepatic vein pressure gradient, and subsequently the risk increases as the pressure increases. And those who have got a hepatic vein pressure gradient of more than 20 millimeters of mercury, they've got a strong prediction of early rebleeding and death. So you need to stabilize these patients early. In terms of stabilization, we use the acronym for variceal bleed, which is vasoconstrictor therapy, antibiotic, resuscitation, ICU, level care, endoscopy, then alternative rescue therapy or beta blockers if needed. So with the vasoconstrictor therapy, it reduces the splanchnic blood flow, of which telepressing is the only target, is the only agent which has been shown to control bleeding and mortality in the randomized control trials and some meta-analysis. Octreotide, it can be used. That's what we are using at our facility. And you can use it for about 3 to 5 days. And there are other alternatives like vasopressin or somatostatin, of which they've been shown, some of them like vasopressin has been shown to have too many adverse effects. Antibiotics, the bacterial infection, they occur in about 66% of patients with cirrhosis and variceal bleed. So the use of antibiotics, it's prophylactic antibiotics, it reduces the incidence of bacterial infections and also significantly reduces early rebleeding. We can use ceftriaxone or a quinolone, of which you may taper it to a 7-day oral course. Resuscitation, it should be prompt but with caution, and your goal is to maintain hemodynamic stability, and restrictive transfusion strategies also needed, like I said earlier, and you need to avoid excessive rapid expansion of volume, which might increase the portal pressures and raising the bleeding risk to be higher. And some patients might need to be intubated depending on their hemodynamic status, and also the need for consultations with other colleagues like interventional radiology for possible tips if the patients qualify. The endoscopy should be done as soon as possible after research within 24 hours. And we do endoscopic variceal ligation for esophageal varices. You can also do sclerotherapy, and for gastric varices, cyanoacrylate injection, but I'll talk about it when I move on in my next slides. And also, some patients might need balloon tamponade or provision of esophageal stents and tips, and also surgical management, of which patients who will end up needing surgical management, which can be non-shunt operations or shunt operations. The mortality is very high. There are some experimental approaches like hemostatic nanopowder, but I think it's mainly in the first world. I will talk about gastric varices separately, about interventional radiology. So the alternatives rescue therapy, that's tips and placement of shunts. That's early placement of the shunt within 24 to 72 hours is associated with improved survival, especially in those patients who have got high risk bleeding, which is refractory to bending. You can also put a sangestatin Blackamoor tube. This offers, it's very effective for immediate temporal control, but he has got a high complication rate. These patients, they may aspirate, the tube might migrate, it might also cause necrosis, perforation, and perforation of the esophagus. There's also use of esophageal stents, and it has been shown, there was a study which was published, which has shown that they are fully covered FCSEMs, they were superior to Blackamoor tubes in terms of refractory esophageal variceal bleeding. They did, it was a randomized control trial for 29 patients, of which 13 were subjected to fully covered self-expandable mental stents. That's why 18, and 15 were inserted with a Blackamoor tube. And the overall success was higher in those who were stented. And also, it was high, the rate of control of immediate bleeding was very high, with less transfusion requirements and also less adverse events. So with your beta blockade, you reduce the risk of recurrent variceal bleeding, and we make use of non-selective beta blockers, of which they cause planchnic vasoconstriction, and they decrease the cardiac output. So moving on to gastric varices, they are rare, but they tend to bleed more severely than esophageal varices, and they are difficult to control, and they've got a very high mortality. And also with gastric varices, you find that the vascular anatomy can be very highly variable and they are not amenable to one particular treatment option. So the goal of initial endoscopic evaluation, it includes an identification of the bleeding source and classification of the variceal bleeding site, of which following the hemostasis, you need to do a cross-sectional imaging that can be an MRI or a CT scan with the portal venous contrast phase to determine the vascular anatomy, including the presence or absence of any portosystemic shunts and gastrorenal shunts. So this slide here, it just shows the types of the gastric varices, of which those which are located in the posterior and the greater curvature side of the cardia, they have got a distinct vascular supply from esophageal varices there, and they are later described as the cardiofundal gastric varices. That's your isolated gastric varice 1 and your GOF 2. Then we have the ones which are located at the lesser curvature of the cardia, and they have the similar vascular supply with the esophageal varices, and they are described as the lesser curvature gastric varices. Then you have got IGV2, which are which you can find them in the gastric body and antrum, and they are described as distal gastric varices. They are very rare and usually associated with splenic vein thrombosis, and their management is actually different from the other gastric varices in other sites. In terms of this classification, we use it's called the Sarin classification, of which the GOF1 are more frequent, and the overall bleeding risk without treatment is actually higher in IGV1, which has got a 78%. These are the isolated varices in the isolated varices in the fundus, followed by the GOF2, which is about 55%, and also with your GOF1 third and IGV2, which are found elsewhere in the stomach, having the lowest rate of bleeding without any treatment. So the management is similar to esophageal varices in terms of the resuscitation, antibiotic, and vasoactive medications. Of all the four types, the GOF1 you can bend them, you can manage like esophageal varices, and also cyanoacrylate injection therapy, it can be attempted if it's available, and coil embolization also coil embolization with gelatin sponge injection can be used, and also together with thrombin injection and elastic bands and some detachable snares. There are several interventional radiological strategies which you can use for gastric varices. You've got TIPS, transjugular intrahepatic portosystemic shunts, which is best for IGV1 and GOF2. And also, you can use it in patients who are refractory to recurrent gastric variceal bleeding, and those who have failed endoscopic therapy, and also those with associated with esophageal varices. However, these patients have got this procedure has got high risk of hepatic encephalopathy, so you need to monitor these patients closely if they qualify for TIPS. Other interventional radiology strategies include balloon occluded retrograde transvenous obliteration, that's your brutal, for gastric varices with the gastrorenal shunts. Then we have got a balloon occluded anterograde transvenous obliteration, of which they go through the portal vein. And also you have got your vascular plug and gelatin sponge associated retrograde transvenous obliteration, the PATO. You are just using the vascular plug instead of the balloon, and it has been shown that it has got fewer complications than Pluto. And also there is coil assisted retrograde transvenous obliteration and percutaneous transhepatic varicose embolization, which is where you use embolization using coils, glue, and sclerosants, but it's less common. So these are the interventional radiology, they have to be familiar with most of these modalities, and depending on their expertise, they can use them in terms of those patients who have got refractory bleeding from gastric varices. So with the endoscopic cyanoacrylate injection, it involves direct visualization and injecting of your acrylic resin monomers that undergo rapid chain polymerization when in contact with the hydroxide ions, and it forms a strong solid chain that causes thrombosis, of which you might need to inject severally for you to have hemostasis. So this treatment, can be repeated every 2 to 4 weeks until there is obliteration of the virus, and then within 3 to 6 months, and subsequently you need to do annual surveillance. However, it has got some complications, of which you can have embolization of glue causing pulmonary embolism or stroke, and also the needle can be impacted in the varix, and it can also induce gastric variceal bleeding. So you just have to be on the watch out for complications if you are using it. So there's also the use of EUS guided injection therapies for the gastric viruses. That's your endoscopic ultrasound, of which it gives a direct visualization of the variceal complex and feeder vessels. So you are actually able to identify the vessels. It's not like you do a blind injection, and you are also able to target your perforating veins, and this reduces recurrence, and actually it enhances the precision of injection during the acute bleeding when direct visualization is impaired, and it expands the available treatment options. And also with the use of JPL interrogation, you are able to provide real-time feedback of hemostasis. And as compared to blind injection, it has been found that there is a low risk of embolization. So there are multiple studies which were done in terms of managing of gastric varices using endoscopic ultrasound, of which they've shown that it has got a very high rate of technical success, around 99%, and the control of bleeding, and also has got low rates of rebleeding, that's about 16%, and the adverse events were very minimum, up to about 7%. And the EUS guided injection therapies, they are best for IGV-1 and your GOV-2. You can either use cyanoacrylate glue injection alone, or you can do the EUS guided coil embolization, and you can do a combination therapy, which is actually the preferred approach, where you use the coil and the glue. So it has been found that using the coil and the coil actually stabilizes the glue, and the amount of glue which you are going to use is going to be less as compared to just using the glue injection alone. And you also have got your EUS guided sclerosants, which is now less commonly used. Okay, this photo just shows the EUS guided injection for gastric varices, where you have your EUS scope, and also how you are going to inject them. And also this, like I said earlier, the interventional radiology, depending on the varices and the shunts which are available, you can go through the gastrorenal shunt to do a brutal. This diagram is just shows the use of EUS in the management of gastric varices, especially the combination use is being used. The combination of therapies, that's your glue and the coil. So the slide B here is just showing you the endoscopic view of a large cardiofundal gastric varice with a stigmata. You can see it's pointed by the arrow there. And this on C, it's just showing you the baseline Doppler flow assessment. That's the flow of blood in the varice there. And on D, the needle has been there's the displacement of the intravariceal needle has been delivered, the coil, sorry, and you can see that the your Doppler flow it is reduced, and finally this was after the glue injection. There was after the injection, after the procedure, it shows after the coil placement, it's just showing you that there's no more Doppler flow. It's like the obliteration has been made. So in terms of management of the acute gastric variceal bleedings, this flowchart just summarizes how you can manage them depending on the location of the varices and whether they are on the lesser cavage or they are cardiofundal, and also the modalities which you can use, and also whether your bleeding was controlled or not, of which if the bleeding is not controlled, you might need to make use of your interventional radiology services. That is, if they are available for your patient to be considered, maybe for tips. That is, if they qualify, or if they are if they've got no contraindication, and also for patients who might need a bruto or a bato for if weight tips is not an option. The same applies to this slide. Is just an overall overview of how you would manage acute variceal bleeding, but this one, it just encompasses the esophageal varices. Moving on to gastrointestinal stromal tumors, the GISTs. These are more than 95%. They express the C kit, that's your CD117, and your poor prognostic factors is a tumor which is very large, like more than 5 centimeters, and also the location. You find that those which are in the small intestine, they tend to bleed more than the ones in the stomach, and also the mitotic index, which is like 5p50 high power field. They've got an aggressive behavior, and the tumor which has ruptured and which is hemorrhagic, it's just a poor prognostic sign, and also other factors like your p53 mutation and KI67 expression. So in terms of risk stratification, they combine the tumor size, mitotic rate, and location. They use the Fletcher criteria and the Mettinen criteria. So what can cause bleeding in these tumors? It occurs in about 30 to 40% of the GISTs, and usually there's mucosal and submucosal destruction by the tumor growth, and you find that there is at times invasion of nutrient vessels leading to the vascular rupture, and also tumor necrosis has been a contributing factor. And also there may be a joint action of digestive juices, gastrointestinal peristalsis, and fecal transmission. And studies have shown that the proportion of stromal tumor bleeding in the small intestine is actually much higher than in the stomach. So when they are actively bleeding, it's advisable to not to avoid a biopsy, because you might even worsen the bleeding. So what are the treatment options which you can do for a bleeding GIST? Or you need to resuscitate your patient, of which surgery is the treatment of choice, of which you need just got a high R0 resection rate. And there are several endoscopic techniques which you can use, and also the use of neoadjuvant therapy, like imatinib before surgery for very large tumors and those with chronic bleeding. That's the imatinib is a tyrosine kinase inhibitor. So the endoscopic management which you can use the saline diluted adrenaline. Like I said earlier, the adrenaline, you don't use it as a single modality. You need to use it as a dual modality, not with another option. You can do sclerotherapy. You can also do plasma argon coagulation, and you can also do clips, either hemoclip or also do give a patient a hemostatic powder depending on the location also and how big the tumor is. But it has got some limitations. You know that the tumor is submucosal, so usually the bleeding source can be deep, and there is a high failure rate and rebleeding rates compared to peptic ulcers. So depending on your choice of endoscopic modality just depends on the extent of the tumor size and how you assess the bleeding. Otherwise, the patient is going to rebleed. So just a final note on a de la Foy lesion, which these are uh, dilated aberrant submucosal arteries, which erodes an overlying epithelium in the absence of any primary ulcer. And it can cause bleeding, which can be recurrent, profuse, and at times itself are limited, of which the endoscopic hemostasis may be achieved with a combination of modalities like your injection followed by bipolar probe coagulation. You can also use it probe thermal coagulation or endoscopic clip placement. And also with endoscopic band ligation, there's a risk for perforation. So if it rebleeds, you might need to repeat the endoscopic hemostasis, or you might need to consult interventional radiograph for your angiographic embolization. And lastly, you might need to consider surgery for surgical wedge resection of the lesion. So, in terms of upper GI bleeding, so for your post-endoscopic management, if it's a peptic ulcer, it's advisable to give the PPI infusion for 72 hours. Then you can follow by oral medication. And routine second look endoscopy, 24 hours post-endoscopy with the endoscopic therapy is usually not recommended unless if there is any clinical evidence of recurrent bleeding. You can do the repeat endoscopy before you think of angiography and surgery, because most of the time it can be successful. And after your second therapeutic EGD, if there is any evidence of further bleeding, or if your endoscopic control is not achieved, then we recommend your IR, that's your angiography or embolization, actually offer surgery. Surgery is mainly the last option. So thank you. That's my brief presentation on upper GI bleeding.
Right, Godknows. Thank you very much for this overview. Yeah, I think it's been well covered. I must declare at this moment that I don't deal with bleedings much, but I think you covered what I think is important. Um, I think let me just find out if I want to find out from you. I've got the answer, so but I'm going to ask you. Between non-varicose and varicose bleeds, which ones should be intervention should be done earlier?
Between non-varicose and varicose bleed, I think I'll go with the varicose bleeding because
Yes, yes.
they
No,
tend to be more severe, and those patients most of the time they've got multiple comorbidities and are unstable, and they've got coagulopathy. Though the coagulopathy is not part of doesn't have any impact on the bleeding, but they are because of the comorbidities and the presence of chronic liver disease, their outcome is very poor. So I would rather manage the variceal bleeds. And if it's gastric bleeding, they tend to bleed more severely. They might need more intervention.
yeah. No. Yeah, thank you very much. Because the thing is, I think it's always nice to judge, like if a patient comes in with bleeding, that if you see there could be evidence of liver disease that can guess it could be varicose, then you should like expedite the management quicker. And then I think those patients you would have to get a surgeon early or anesthetist because they might have to go. You will be successful better if they are anesthetized fully, I think, those patients. Right. And then, yeah, what I'm saying is that for the non-variceal bleeds, like peptic ulcer, the rest that you've mentioned, there is adequate time for resuscitating the patients adequately, actually. So I think early PPI therapy so that we can increase the pH so that the clot, whatever clot is being formed, can be stable there. And then you can have your time after 12 hours, close to 24 hours, you can go and scope those patients comfortably when they're well resuscitated. And then I can also attest to the fact that the varicose patients, if you resuscitate them too adequately, like fluids are fine, they bleed again very profusely. So I think that point is very important in terms of having that feel that it should be just adequate resuscitation for stability, basically. Good. And I think, okay, then there will be, it's good to know that the forest 2B, you have to remove the clot. I know it's scary, but it should be done. Then you should either promote the lesion to 2A and then you can deal with it with the dual therapy. That is very important, I think. And then I think there's a message that should come in that if you are practicing as a GIT specialist, whether as a surgeon or physician, but in this setting, there's a minimum equipment that you should have. You should have adrenaline, I think, and then you have to have your clips. Those things have to be in the stock minimum. Obviously, you can go to Ovesco clips if you have more money, but I'm just saying there's a minimum equipment required to run a proper resuscitation in terms of upper GT bleeds. The things about this, the hemosprays and the next powders, I feel it's a good to have, but it's good to know for your academic purpose. It's good to know, but I think it's a nice to have. This is my opinion. Good. Then we do have patients who have chronic pancreatitis here, who end up having some splenic vein thrombosis because it runs on the superior and posterior part of the pancreas, the splenic vein. It thromboses easily. And then those patients later come with these isolated gastric varices, which we miss because I think now we are aware that we have to look very carefully in the fundus, look for those snake-like things. They're invariably not blue like the ones that you get in the esophagus, you see. It will just be dilated, but still having the same mucosal color with the stomach, like the pictures I've shown in your EUS pictures just now. So it's very important that you talked about the EUS, and I think from where I'm standing, I strongly recommend that a modern gastroenterology guy who's like more than one should have some training in EUS. I know there's debate about they should have been conversant with ERCPs, those things, but I think EUS is important tool for a modern gastroenterologist to invest in because you can see it can help you to do the coiling there for those who can do coiling or even inject properly. And also you can even decide on those gists that you have mentioned as to how deep they are. So if you have ES, and otherwise it's going to be a CT scan, it's going to take long before you get to the answers. I do not have experience with injecting anything there, but what I do know is that cyanoacrylate is very difficult to work with. It's very difficult. They will tell you that you should put the scope, I think the needle or the scope in some cooking oil or some olive oil so that it can get lubricated so that that glue does not attach to the scope. It's extremely difficult. So I think the EUS thing with your coiling it's if people are well trained is quite something which is very useful. So I think from there I will invite comments from my colleagues. I think I've seen my wonderful colleague here, Dr. Fredericks Ernst. Anything else that you can add, perhaps? Eh? Hi, Ernst. What are you doing?
I'm trying to unmute, as you can see, but I think he covered everything very well. I think it was a good presentation, and as often the case is with fellows presentations that they go way over, above, and beyond, and that's what happened here as well. But I think it gives material for fellows to work with And I'm happy with this. I really don't have any burning issues that wasn't covered. So I'm content.
Good. Yeah, so yeah, thank you. I think I appreciate that very much, Dr. Ernest. Thank you very much. Any other comment? I think we are on time. So that was a final comment from the big guy. Thank you. So,
Hi,
hey,
Gigi.
yes, 1
How are you
minute,
doing?
please.
1 minute. I think I may have missed it, but did we speak to, or is that going to be something in the future about how to handle an upper GI bleed in somebody who's on anti-platelet agents and anti-coagulation, especially the high-risk patient? I don't know if Dr. Shamhuyashe wants to just speak about that. It's a bit of a long topic, but I think it's actually something that's often asked about, the elderly individual who's had a CABG or a stent placed in and is now on aspirin and clopidogrel or your warfarin or one of the new oral anti coagulants, and now is an upper GI bleed. When should you stop it, for how long, etc., etc.? Do you want to just
I think,
Okay.
Gigi, I wish to
speak
protect.
to that?
I wish to protect the presenter
Like you got
because.
those.
Can you hear me?
Yes, okay. So with the patients who are on anticoagulations and antiplatelet who come in with upper GI bleeding, you have to stop the anticoagulation then. But you need to liaise with if they've got a cardiology problem, you need to consult the cardiologist. It's a multidisciplinary management. And those patients, depending on what medications they are, if they are on DOACs or if they are on warfarin, especially the patients who are on DOACs, you might find that the reversal agents, like for rivaroxaban, for example, adrenaline alpha, is not available even for dabigatran. They are not easily available. So you might end up needing to give these patients uh, four-factor platelets complex concentrate. Then after you have achieved the hemostasis, they need to be reintroduced to their antiplatelet or anti.
Yeah, depending on obviously if they've had how long do they need antiplatelet agents. I think there are some guidelines out there. So I wouldn't ask you to actually explain all of it. It's going to be a long conversation, but just for the fellows to be aware that is something that's often asked either in a written or a oral exam. Sorry, we're a little bit over your time now. Thanks.
All right. Okay, Viji, that's a very important point. I think, God knows you will visit that thing because you have to assess the reason why a patient was on those drugs. Like you are right. If you want to stop them, you have to consult the cardiologist as to why, so that the risk can be weighed against the benefit, all those things. Okay, thank you. Right, let me see. We're over time, guys, but thank you for attending. Very important subjects. And thank you for everybody. And thanks to ECO, University of Mexico, and the ECO India team for the support. The recordings will be available on the Gastro Foundation website. And then, we have to thank them as well. The next session will be on Monday the 18th. Monday the 18th should be 14 days from now, 6 o'clock. Is going to be the pre-malignant conditions of the stomach. Pre-malignant conditions of the stomach. It's polyps and possibly gastric cancer. Dr. Mithun John, I hope I'm saying it right. Is Mithun or Mithun? I'm not sure, but it's Dr. John. And Professor Nazir Choptat should be the coordinator there. So with that, ladies and gentlemen, have a great evening.